Thanks, everyone. And thank you so much to the panel. Can you hear me okay? Everybody? Great. I'm Mary McDaniel. I am very, very excited to have our panel today and call out to Craig Richardville, who's coming from Denver. And thank you so much, Craig, because having your perspective on our Southern California HIMSS meeting is greatly appreciated. Craig is the CMIO and SVP for Sisters of Charity, which is SCL Health. For those of you who don't know, that is an 8-hospital system headquartered in Denver, Colorado, and also includes the state of Montana. And Craig has really been an active member of HIMSS for many, many years, and actually was the recipient of the John Gall Award from Chime and HIMSS in 2015. And he was also the CIO of the year in Denver for the year 2020. So we're very, very thrilled to have him. Again, Dr. Linette Scott. This is so great because we have Craig representing really the not-for-profit hospital perspective, and now Dr. Scott, who is the CMIO and Deputy Director of Health Services for the state of California, who's presenting a different perspective in her role as the data expert for the state of California Public Health. And I think what's unusual about Dr. Scott is not only does she have her medical degree, but she also received her undergraduate degree in physics. And I think it was Santa Cruz, and her master in public health from UC Davis. And finally, Jim Davis, who has been really the expert on the ground for working with UCI and setting up for the last 6 years a very, very sophisticated infrastructure for IT, and also architected the infrastructure for both UC San Diego and UCI Irvine. So thank you all very much for participating. Again, we greatly appreciate it. And I'm really excited to hear these different perspectives from your backgrounds and experience on kind of continuing the theme of today, and understanding how COVID has just been a pivotal shift for all of us, as we've heard from the clinicians earlier, Dr. Murphy, Dr. Swami, Dr. Jamaluddin, just their perspectives on how telemedicine improved the connection between patients who would normally probably not show up in the hospital, but now they had a teleconnection way to communicate with their physicians, the improvement that made. Just all these things that have really maybe been a struggle, or maybe brought some value to what we've traditionally worked with in healthcare IT. So I just wanted your perspectives first on that, and what you saw in the very beginning as some of the significant challenges, and then how these challenges made an impact for the good or the bad. And I know we had the struggles and the bad, but your thoughts. And I'm going to start with Craig, because I know you're very well immersed in this, and your perspective coming from SCL Health is really important.
So in terms of some of the challenge I think many of us have seen with COVID, and how we're kind of working our way through it, and have really positioning the whole industry, in my opinion, for great success in the future. Several things that we had to work through is just the speed, getting things fast to market. That was an important aspect of the work that we did, and the work to be able to accelerate things that we had laid out over a period of time, and to be able to do that quickly. At the same time, agility became a new skill for many within the industry, to really kind of lift and shift some of your priorities. Not that you are changing any of your priorities, but really just kind of just being able to kind of move things over in that direction. So things that maybe were at the top of the list are now in the middle. And then data integrity. I think we all kind of learned that we thought we had pretty good data in place, and we did, but the preciseness of the data that we need, the timeliness of the data that we need, we didn't know. We really didn't only know how many events that we had. We had to know what type of events, and could those events be converted to multiple patients. And probably at the end, I think it was a nice outcome of it, is we saw in all the regions that we practice in 3 states, is really the communities coming together. So whether that was sharing supplies, sharing resources, trying to make sure that we all kind of work together in this as not only as a system, but as a community was really a nice outcome.
And Dr. Scott, your perspective from the state level.
Hi, just to add a little bit about the work I've been doing. Most recently, I began at the state in the Department of Public Health, but I've been with the Department of Healthcare Services now for about 9 years and serving as the Chief Data Officer now. Went through a title change about a couple of years ago. So Department of Healthcare Services, as I'm sure many of you know, it runs our state Medicaid program, Medi-Cal. And so needless to say, as COVID-19 came in, there were both the organizational changes, within a week going to 85% telework and everything that went along with that. But also the massive changes in terms of the COVID response. So our programmatic teams had a tremendous amount of work with respect to flexibilities, what could be allowed, requesting for permission for that from CMS, implementing it both at the state level and then working with our partners at the local level. So a huge response and a huge transformation. And certainly as the COVID pandemic started to play out in a very real way during the spring and summer last year, it became the primary focus of almost everything we were doing, but both within the Department of Healthcare Services and then working in partnership with our other departments, public health, social services, and collaborating both in terms of sharing staff as well as working together on various projects and efforts. So COVID-19 definitely made a significant impact in many ways. One of the programs that I have in my portfolio is our electronic health record incentive program, or the Promoting Interoperability program. So certainly as part of that effort and working with folks across the state, we started hearing about some of the different issues around data sharing, access to data, that certainly the pandemic response highlighted where we have issues and opportunities. So it's been a transformative and learning sort of year in so many ways. Thank you.
I think we can all say that. Very transformative
Yeah.
and ongoing learning, and it will probably continue to be like that. Jim, what's your perspective?
From the technology side, we had a lot of supply chain issues in the beginning. I'm sure everybody, was quick to trying to separate a lot of the clinicians throughout the hospital is trying to not have as many shared devices as more dedication. So we were scrambling, eBay, every site you could possibly to find webcams to come up with unique and innovative ways to stand up what we consider a workstation on wheels. We were getting down to going to certain supply companies to get carts and finding UPSs and putting monitors on this so that we could give our clinical staff their own dedicated, workstation on wheels. We found it even worse was we really didn't understand, I think at that time, how much we were working and not adhering to some of the best practices. And I had some of my staff, come down with COVID, which then meant we had a lot of people. So individuals like myself and other leadership were doing things that we were not normally used to doing. And we found out that how quickly we had to, get our skills back up to speed and go through run books and make sure they were up to speed in case, an event like this happened in the future.
Well, I hope you guys can see this halo behind my head. It's glowing because you guys look great. It's just what you say, it's a halo. I think that's very impactful. And I also think a lot of us have had the same struggles and the same issues. And I think a lot of strategic initiatives at the senior leadership level of these organizations have shifted. If you all noticed that, and I'll just open that up to everyone. If you've seen dollars reallocated to different areas, has it affected technology? Have you seen a boost in that? And from the fact that technology was such a critical component for COVID for many, many reasons. Have you seen that impact?
I'll start out really quickly. So I think one of the nice things that happened was we went through every single project as a leadership team that we had in place to see what needed to be changed, reprioritized, the benefits that we're expecting from that. And the one thing that it did validate for us, and we actually then met with our board about the same thing, it validated actually that our strategies that we established were correct. And we were really just trying to maybe accelerate and maybe some slight shifts of prioritization, but the things that we put in place for, empowering and aligning the organization from an employee perspective, growth, clinician network, transformational work on both the clinical as well as the non-clinical piece. Those are all aspects that really COVID kind of brought to light and allowed us to be able to continue to accelerate that work. So we didn't see any change as in our strategies at all, other than the potential of the acceleration piece of trying to do things a little quicker. And then from now moving forward, it really has allowed, I think, us as an industry and as a health system is to be able to continue that advancement, because you've gotten some things off the plate that would have been on the plate maybe for a longer period of time. And that's really been, I think, a nice thing for us, especially as you're looking at the industry changes with some new retailers getting into the market and more tech companies get into the market, that we are positioning ourselves to be very competitive as well as collaborative. The interoperability and the data sharing comment, there's a lot of things that we can continue to mature to make sure that we're treating the populations and the communities first, putting our patients always smack into the center of it all. And then we'll compete on other things, but that, we really want to make sure that we do serve those communities as a total industry as opposed to as a health system.
Yes, and I know that's a integral component of the mission for SDL is really, I think, aligning the strategic goals of technology with those goals of the ministry. And I think that's probably true for Dr. Scott and for you, Jim, too, at UCI, because really at the end of the day, we're about healthcare and trying to impact our communities and at the same time, reduce costs, improve quality, and make this a safer world for all of us. So, Dr. Scott, have you seen this change at the state level? Have you seen some different shifts in priorities or strategic initiatives because of COVID?
Well, certainly the COVID response itself became the priority. So last year, as the calendar year was beginning, there were a number of things that came out in the governor's budget that were priorities that we outlined for the Medicaid program and others across state government. As we moved into the response and we moved towards the May revise, which was 1 year ago today, there were a number of things that were proposed as reductions that in order to be able to focus on the response to COVID. So those things went on hold. There was obviously the conversation between the administration and the legislature. So what was proposed on May 15th and what was passed by the legislature, it's a conversation that happens and is being kicked off again today. As we moved through the COVID response time, there's a number of things that happened. Certainly work in the public health arena to be able to support the reporting, testing, vaccinations, et cetera, have driven several things that I think were on the priority list, but they became more so and jumped forward in a number of ways. And as we moved into this year with the governor's budget in this calendar year, some of those priorities that were there last year are there still. So it's not that the priority went away, but the focus had to shift to be able to respond to the pandemic. So we now continue that. So as a Medi-Cal program, many of our programs are very much focused on integration. How do we treat people as whole people? All of the aspects of care they need. What does that mean to integrate across behavioral health, physical health, and other support services, health and human services? How do we have the patient-centered care, patient at the center, data-driven activities? So very much the priorities of our Secretary for the Health and Human Service Agency and our administration, I think, have stayed consistent. What shifted during the pandemic response was where we needed to focus in certain respects, but the overall priorities remained consistent, and we continue to work towards those.
Well, that's a great segue into our next topic, but I want to touch base with Jim before we move on. Have you seen a shift in strategic initiatives or priorities at UCI?
Absolutely. We were probably 3 weeks away from really kicking off a telehealth initiative, here at UCI Health. And as soon as the pandemic hit, something that we had slated kind of rolling out over 6 months, partnering, as I say, to buying things off of eBay, we were literally scouring webcams off of desks and through eBay with, help of our clinical leadership, just literally going out and we knocked it out in 3 weeks to be able to go full telehealth, here at UC Irvine Health. There were other initiatives too. We realized that there were some deficiencies with wireless as more and more devices come in the environment. It was just something that was not prioritized. But now that you've added more devices for each of these, clinical staff members, we were putting access points outside of hospitals. We were putting them and converting conference rooms to be more, more user friendly. So there were a lot of shifting priorities is where they were probably more later in the year. We were pushing all of that stuff up front and really, getting creative in how we were finding through the supply chain, how we could actually deploy some of this technology in such a quick time frame, as well as the ongoing support for work from home. Rather than buying everybody a laptop and sending them home, really ramping up our virtual desktop deployment so that we could send staff home and use existing equipment when we were just not getting access to the stuff we needed.
It's just amazing to me how much effort goes in behind the scenes for a technology team just to be able to deal with this. I don't think a lot of hospital administrators understand what we've had to do, just from the technical, like you said, what do we do with setting the digital workplace at home? How do we make sure we have wireless available? I mean, there were so many points of contact and communication that could have failed. And I really applaud the efforts of all the IT guys and women that were out there trying to make this seamless transition, or as seamless as possible. And I think on that note, and sharing data and getting back to what really is whole person centered care and the ability to collect and store and analyze and measure data, which is really the end goal and really what value-based care should ultimately be all about. I think it's been a struggle for all of us to look at how are we going to exchange data in the future, and what does this interoperability mean in reality. I think it's a great leverage that the government has made to push towards interoperability and push towards data exchange, but I know that there are many independent hospital systems and other independent healthcare provider systems that don't necessarily have that same view, and some of those concerns are quite legitimate. I was just reading some statistics from ONC from 2019, a latter part of 2019, where, and we all know this because we come from IT and we've seen the legacy systems evolve over time, and 59% of the hospitals reported that an exchange partner's EHR system wasn't able to receive the data. And another interesting statistic was that 48% of the hospitals reporting for this particular study had to build custom interfaces to exchange data with other providers. And I think this is an interesting perspective because I'm very passionate about interoperability. I came from the AWS world of sharing data, and then sometimes getting that discrete data into a record that can be shared and is effective data and accurate data. It's just been a challenge. One of the end results of that is some states have had successful health information exchanges. They've been supported by their local governments, and they've been provided some kind of interoperable platform that can contain payer data, clinical data, social determinant data, et cetera. But that's not really very common. And some of those exchanges that initially started out with public support have become private entities and have not been able to create a sustainable model moving forward. So I think I'm going to start with you, Craig, because you did testify to the Senate Health Committee not too long ago with, I can't believe remember the physician from University of Washington, I think with Neil Patterson from Cerner, but your thoughts about this and, how you felt our federal audience received your impact and your feedback on sharing data and interoperability.
Yeah, that was a fun opportunity to be able to do that and share thoughts and ideas on that. One of my brothers was a Senate Majority Leader in the state of Michigan. I tried to get some governmental tips from him on how should all he said was wear a red tie, so I did. So,
Well, you didn't wear it. That's good.
but in terms of, I think, overall, certainly it's always been a kind of a challenge, and it's an evolution, for the industry as, we're 20 years into automation of the EMR and all that relevant data. And we had, the competitive different systems and that kind of thing. I don't think there would be anybody in our shoes that would say interoperability, needs to be certainly open, transparent, and the data needs to flow freely. Because, and we looking at trying to administer and provide care, you want the best information to be available. And it's not competitive of who has the data and who doesn't. We should all be working off the same data. What we use and how we use that data is where some of the advancements or some of the differentiators can come in between health systems. So I'm a big fan of doing all of that. I don't really believe, and I testified actually at that time, intentional information blocking. It was more of a competitive, and so there needed to be some neutral place for the two big horses in the race to be able to share information back and forth to take place, because they do kind of see you need to be all of one or all of the other, and neither of the two should come together. So at that time, us and another large healthcare system in the Carolinas actually exchanged data between Cerner and Epic freely. To give those names out, but there's also many other platforms and things that are out there. So, and nobody was intentionally doing the blocking. It was just who was actually going to give up. And now we're starting to move into our standardization, the enforcement, the consistency. It really is starting to move, I hope, in a manner that it's not really the healthcare systems to be able to do the work. Talked about custom interfaces and integration, but really those technologies need to have those open standards to exchange. So it doesn't really matter what Jim uses, it doesn't really matter what I use or what Linette might be using. If we're sharing data, if those standards are in place, it shouldn't matter. So we're kind of, in my mind, trying to move that over into the responsibility of the different partners or the vendors doing the work, so that that's in place. The government doesn't want to get in and set those standards and that kind of thing, and that's not their responsibility. It's up to us to be able to help drive and make that happen. But if you're looking at a financial side, and you look at if you go to apply for a mortgage, all your financial history, no matter who it is with, is available, and they're able to make decisions on your credit risk score of how they want to, what rates they're going to give you. It's a yes or a no, et cetera. And I can't take things out and say, oh, by the way, they forgot when I filed for bankruptcy 10 years ago, that was, in the system that they can't communicate. No, it's all there. I think the complexity that we have is that's putting it very simple. And the reality is we're talking about thousands of times more data assets, the size, the complexity, the trying to get the data integrity and the normalcy between us. So when I'm bringing in two lab results together, they both have the same acceptable ranges, and I can just really kind of do things together. That's going to, again, be a little bit more of an evolution, but I think the industry has made great strides towards that. I do think we have a ways to go. And I think most of us are saying this is not a competitive thing. What we do with the data will be a differentiator, but really having access to the data, we all want access.
Yes.
If I'm in Florida and I get hurt, I want that provider in Florida to have access to everything about me before he or she makes a decision. And I think we would all agree with that.
I think that's a really accurate point. And sometimes I don't think it's necessarily about the competition. I have witnessed that from the payer market a little bit in some of my statewide HIE implementation projects, not so much from the hospital side of it. But Jim, you're coming from an entirely different setting within an academic setting, which still has some structure to it, and you maybe want to be more innovative at times than, you'd like to be. But what's your experience been with just the whole notion of information exchange at UCI?
Well, thankfully, I'm not the CIO, so he has to, I think, deal with a lot more of that. I'm just responsible for making it all connect in the security. The beauty that we have here is UC Irvine Health and UC San Diego Health. We have a shared EMR. And thankfully it's hosted. So, we get to really leverage the relationship with, with our vendor to help push that. So I've seen a lot of collaboration just between those two schools, Irvine and San Diego, and what we can do for, the greater Southern California area. And really that we've done this, I really hope that, everybody's kind of looking at what we're able to do, and that can start to expand. So from a technology side, absolutely. I couldn't agree more with what Craig was stating. I want to be able to go anywhere and, the continental US and even go to Alaska and Hawaii. And if something were to happen to me or my family, to have access to all of that very critical data.
And Dr. Scott, I think also, not only this question, but your perspective about, I know there was some yin and yang between the public health agencies sharing information with some of the healthcare systems during the COVID, like who owned what, who was responsible for what. And there was kind of a debate going on about where was the ultimate source of truth going to lie between those organizations. And I know the state of Nebraska, for example, the governor made a mandate that the state health information exchange would be the single source of truth. And of course, Nebraska doesn't have the challenges that California or Colorado has. It's a smaller state and it's a little bit more compact from a technical perspective, but it took a governor's mandate to say, we will use the public health system as our single source of truth. So your perspective on that in your role as a CMIO.
So thank you. And I'll have to defer to some extent because I'm not with the Department of Public Health at this point. So I'm with the Medicaid program. So I can't speak
Medicaid,
for the Department of Public Health. But that being said, I think one of the challenges that we have around some of the data sharing is the way our statutes were written. So California does have a very different legal environment than some other states, both in terms of having a constitutional right to privacy, which affects a lot of the ways in which we consider data sharing, as well as in some of the normal differences between states in that things like public health registries are often state administered, and so it's the local state law that then governs as opposed to a national law. So those things definitely impact the way data is shared and how that's done. From a broader perspective, perhaps, one of the challenges I think we have in California is our size. So I've been working around the HITECH Act and all the things that we've been trying to implement under it for the last, 12 years now. So I started with it when I was at Public Health and served as the Deputy Secretary for Health IT for about 14 months on an interim basis, and then have worked with it from a healthcare services perspective through the Electronic Health Record Program, Incentive Program, which is now the Promoting Interoperability Program. And so California very much, we have a network of networks approach that we started under the HITECH Act back in the 2009 to 2014 timeframe. As the federal funds under the initial HITECH grant ended, the California Association for Health Information Exchanges, CAHI, was formed, and they've taken on that role to serve that voluntary glue, so to speak, using the CalDERSA, the California Data Use Reciprocal Sharing Agreement, and the C10 California Trusted Exchange Network, to provide that framework for sharing between the different health information exchanges, both community-based and enterprise-based across the state. So as a state entity, and I think as for many of the state entities, we need to interact with the different health information exchanges. Department of Healthcare Services has onboarded to the C10 and the CalDERSA, as has the Emergency Medical Services Authority. And so we want to keep supporting that. In the governor's budget in January, one of the things that was part of that was a direction to say that the administration was going to be looking at providing leadership and supporting this direction, again, in terms of looking at a network of networks. So what do we need to help these networks be glued together? What are those common rules of the road, piggybacking on the federal requirements, obviously, but being able to make that work in California California, given the robust nature, the diverse nature of the various health information organizations. You know, some have really grown and built a lot of their support with partnership with, say, behavioral health. We're seeing that more and more. Others are very much, we're built based on a focus of collaborating with public health. So there's some of that data exchange with public health has happened at the local county perspective, whereas maybe it hasn't happened as robustly at the statewide level. But I think all of those conversations are underway, and there's a lot of work going on in that space. We recently hosted on April 20th HIE Summit for the state. The materials from that are on our the event website, which was hosted by California State University or Sacramento University. And one of the sessions was having public health specifically speak to this issue, and they talked about it and had a couple of the health information organizations speak to how they were working with public health to help provide data related to COVID. So I think we've seen a lot of transformation over the last year, but there's still a lot of work to do.
Jim, in your neck of the woods, do you work, for example, with the San Diego Health Information Exchange? Do you all share data? Because really, and correct me if I'm wrong, I don't think we have a robust HIE in Orange County. We have a few small pockets, but
yeah, I think with since we have kind of a single EMR between us and San Diego, you know, obviously as patients can go, you know, north or south, you're in there, you have a single medical record, but the HIE, I'm not aware of anything that's super robust that we're leveraging at this point.
Craig, I know in Colorado, Correo has been kind of a leader in health information exchange for many, many years, and that the whole organization has kind of evolved. Do you all actively, do you know if your clinicians access the Colorado HIE? Just curious.
Yeah, they do. There's no doubt about it. We actually have two in Colorado. There's one on the western slope called QHN, Quality Health Network, and there's Correo, who takes care of kind of the greater Denver and this side of the Rocky Mountains. Then in Montana, we have one called Big Sky. So we're very much engaged with the HIEs and making sure that that for those of us that are maybe on some disparate systems across, and again, many of that are independent in other practices, because we're pretty well ingrained with a couple of the big vendors in most of the healthcare systems in our markets. But you got to exchange with everybody, because there's those patients are always being seen in other markets, and certainly when you go out into more of the rural or some that might be a little more underserved, those create another variability of access to the data and what systems you have to interchange with. So yeah, we do very active with all of our information exchanges.
Well, I think for rural health, as you brought up, it's a tremendous asset, because many times, I mean, I live in Idaho, as you all know, and when you're in northern Idaho up in the mountains and something happens, unfortunately it does, they don't have access to your medical information unless they go to the Idaho Health Information Exchange. And, you know, it's very, very useful and very valuable to have that kind of data available when and where it's needed. I think one of the other questions I had about the whole information sharing too is a little bit off the subject, but I think it's really important, especially based on some of the conversations earlier today, is about the whole notion of capturing social determinant data within our traditional EHRs. And because you all are directly working with those vendors, are you seeing more of a push to collect behavioral health data or other social determinant data, food, nutrition and security, housing, transportation? Are you seeing that, or physicians or clinicians requesting that information? Just curious about your thoughts about that. I'll start with you, Dr. Scott.
So in terms of social determinants of health, you know, that definitely is a push in a number of ways. A focus both at the national and state level, understanding where there's health equity and health disparity issues. So we are also focusing on it from the perspective of how programs are being designed. So again, that integration across various services, both physical, medical health, behavioral health, as well as health and human services, so social services, because it all interacts. I mean, many of our folks in the Medi-Cal program are also in CalFresh, WIC, CalWorks, et cetera. So some of the work we had done a couple of years ago in partnership with the University of Southern California, the Children's Data Network was doing some linkage across those different programs that we have within the Health and Human Service Agency, and how many people are actually being served by 3, 4, 5, 6 different programs within our agency. And so understanding that and looking at how we can integrate services across that and integrate the experience is definitely something that's a focus area for us.
And Jim, how is the focus on, are you seeing the same thing at UCI?
Well, you're tossing some good zingers at me today.
Me to be doing that,
No,
but I,
from the technology side, I can't speak to exactly what we're doing. I'm not super in depth in what we're doing at the clinician level, but I can speak that I know that sitting in there with our clinical leadership all the time, our entire community here is always looking at what information can be gathered that's going to help determine the better health of our patients here at UCI. So every day we're looking at better ways to collect data, and then how do you take your EMR or even research data, and how do you compound all that together to come up with a better possible scenario and solution for patient care.
well, that's where it really isn't a zinger for you, because you have to put it all together. Somebody has to do that, right? We keep wanting more data, but how are you going to hold it? Where are you going to store it?
Yeah.
And your perspective, Craig.
Yeah, so I think we all would agree that in the fee-for-service world, it really wasn't as relevant and not as important or a priority. But in a value-based pop health, and you look at somebody like the state where Dr. Scott is trying to manage populations for the whole state, those are places where those social determinants to help us to try to get involved and interact with the patient, engage with the patient before certain comorbidities take place, or they get more in an acute setting, or they're further down the road, to be able to come in and understand what those things are, not only to change it, but also to manage and monitor those before they get to be an extreme case. It's certainly important. It's a key part of moving into the value world of healthcare. I think we've been talking about it for a decade. I think it's going to start to continue to hopefully accelerate here in the near future, where we really are starting to look at preventing health or preventing care and providing good health. And then when they do get to the care side of things, hopefully then, we'll be in well positioned for that. And it'll be those that are the most acute. But it's like many other things in our life, your car or your house, the more you get into the prevention and understanding all the different things that happen that get you to the point that something needs to be cared for, that if you provide more of that upfront maintenance and trying to help people in certain situations, and mental health was brought up earlier, as you start to get involved with those, you'll see less and less on the extreme care side. And that's really what we want to try to gear ourselves towards. Right. So as the incentives continue to shift, that will then be the focus of the work.
I think that's a very important point. That at the end of the day, it's really about people and how we feel about our communities, the institutions that we represent, and what value we can bring to not only our families, but it's people collaborating, looking for care and preventing care and reaching out, which is almost anathema to what we've been doing, for the past 20 years, and especially in IT. We've been collecting clinical data, we've been treating the sick and not understanding that you said, I better go get my car fixed, or I better do something to change my oil. But I think that's really an important component, because really at the end of the day, it's our communication between the state, between your organizations as a not-for-profit. Jim, you're representing academic medicine, how we can all work together collaboratively and share information, because a lot of times we don't have the chance to even talk to colleagues to say, here's something we're doing in our community, here's a good idea, why don't you try it? So at the end of this conversation, I just like maybe your perspective or your advice or recommendations that you might have for our audience on what should we do to prepare for future pandemics, but also, and I think Craig, you answered it pretty clearly, what is our role now in our community as a healthcare provider, whether it's state, academic, not-for-profit, and how do you, and it can be your, Jim, it's not a zinger, it's your personal opinion. So I'll start with you.
Yeah, I mean, obviously having, better access, across the entire, medical field here is having that data accessible. I think with what we've seen as well is how do we start to put, devices into patients, hands that we can now start to see inside their world, so that we can be more proactive and get them in here, but still be able to take care of them while they're at home. I've also seen, to prepare for things is how do we start looking at kind of more cloud-based options that can use commodity hardware. When we saw, COVID kick off, we were relying on supply chain and our normal channels. So if we have the ability to leverage the cloud, which was never really impacted during COVID, we could have taken advantage of, running the Costco's and buying up a bunch of Chromebooks, and I can send these home, taking iPads and handing them to patients and being able to push some software to them. So I think, looking at how you can start to take advantage of that technology in the cloud would really help in the future to be able to do whatever it is that we want to do, and especially in a timely manner.
And Craig, you mentioned this earlier too, about data storage, and I totally understand the cloud. Like I said, I come from the early days of AWS when there were a lot of cost involved with cloud storage, a lot of complicated things trying to work out, and there really wasn't a whole lot of competition as Google and AWS. So what are your thoughts on that cloud storage?
Oh, cloud in general, cloud for storage, cloud for compute,
right?
Cloud for all services for me is certainly a direction we actually are moving forward with. What we're calling the SEL Health Cloud, which is a combination of public, it's a combination of some on-prem, it's a combination of software as a service, and moving ourselves that way. So if you looked at all of our recent investments, and I look at all of IT as an investment, there's other things we can do with that money. So we've got to be able to calculate the return, whether it's financial or clinical or otherwise, back onto the system. Is everything has been moved towards software as a service. So as we move to Salesforce, ServiceNow, Oracle ERP, our Kronos is in the cloud, our Dragon is in the cloud. All these new services that we have are all being born in the cloud, which then allows you to be able to start to, undo your physical assets that you might have in data centers, which are expensive, and they're not a differentiator for you. There's and the cloud really is nothing but a very huge data center that has a lot of redundancy built in and access everywhere. I mean, if you go to a place that's hosting a cloud, it looks like a data center. So you're really just kind of like offloading that work to somebody who does it as a core part of their business, and allowing you to get the efficiencies and the access, like Jim's talking about, the ubiquitous access to that information coming back in. So I'm a big fan of cloud first. I'm a big fan of mobile first, and obviously in healthcare, it's patient first.
Right. Dr. Scott, you have a unique challenge from a technical perspective, and also it's hard to maybe take at the state level view what the direct impact is on the patients that you serve, but just your thoughts on where technology is going with the state, where your hopes might be, or where your wishes might be, or maybe what we need to be voting for. But what are your thoughts on these subjects?
Well, I keep coming back to, the best way to prepare for an emergency is to practice what you need during the emergency in everyday life. I started off in the military, and we very much had that kind of motto. So what do we need to do to take care of patients every day today effectively? And that is being able to have that full picture of their health data when they come into the office. So so that's our goal. And there's so much of what we're doing at the state level, at the federal level, that is trying to push that goal. So that if somebody travels from Northern California to Southern California, the provider can do the query, get their record, and be able to treat them effectively, and not try to guess what the yellow pill, the white pill that they're taking is, right? And that's not good medicine. So we try not to have to guess. So that's the goal, and I think we're doing a lot to move in that direction. The new interoperability rules that have come out from CMS, they were, I keep saying new, but they were actually issued a year ago. Put requirements on Medicare, Medicaid, our managed care plans, the federal benefits exchange, which in California we have Cover California, so it's not the federal benefits exchange. But we're all working on how we implement these things, which are basic building blocks to be able to have the data move to where it needs to move when it needs to move, and to put the patient in control. So it's the interoperability and patient access rule, because we want patients to be able to access their information. It is definitely transformative work for our environments. We've been focused around things like HIPAA standards, transactions, claims. So making this shift to FHIR APIs, US core data for interoperability. It's different file formats. So those of us in sort of that kind of geeky space, right? It's data mapping, it's processing, it's getting used to new formats. But it fundamentally is so that we can put patients at the center, and patients as part of their own care team to achieve the outcomes that we're all hoping for.
That's what we all would like to have happen. I have a question here for Dr. Scott, and the question is, how much is HHS sharing successes and lessons learned across states? So, for example, we had a guest keynote speaker this morning, Dr. Sullivan, in a somewhat similar role with the state of Indiana. And I know this because I've been to public health informatics forums for several years. But there is capability, and I'm sure you all have, like with public health informatics, a chance to share your thoughts between states.
So certainly one of the things we try to do is collaborate with our state partners. In the Medicaid arena, there's a number of different avenues through which we reach out and interact with folks in other states. So some of them are structured based on state-generated collaboration. Some are come from CMS coordination and the various associations that work with all of us. So that brings a lot of robustness to being able to learn from each other, and we very much are trying to create that culture as well. As being good stewards of tax dollars and public trust, we want to make sure we're not starting from scratch if we can learn from somebody else. So we very much are trying to do so.
Now, I think that's the benefit of like the Southern California HIMSS conference today, is just listening to other viewpoints and understanding what people are doing across our healthcare landscape. It's always valuable to have collaboration. I could open it up for questions right before we sign off today. If we have any coming in. I'll give it a few minutes, but thank you all so much. I really appreciate the time and effort. Dr. Scott, I know you're busy. Jim, you're busy, and Craig, you're busy. You can't ski right now, so. And Jim, you can't go hunting right now.
No, not
unless
yet.
you come to Idaho. But anyway, I really want to thank you all, and best of luck to you, and thanks so much for your support. And with that, I'll turn it over to Sunny.
Hey, Mary.
Thank you.
Mm-hmm.
Just one quick thing. So I want you to embrace the halo effect.
Oh,
because for those of us
like
with a natural halo,
yeah.
I think it looks good.
Well, if I could just walk around with a halo like this all the time, my life might be a lot different. I wouldn't be coming serving cake to you. Well, I do appreciate it, and thanks for acknowledging my halo.
Thank you, Mary.
All right, take care, you all.
Thank you, Mary. Thank you, Dr. Scott. Thank you, Jim, and thank you, Richardville. With this, we are ready to conclude our event. I really want to appreciate all the speakers. I thank all the speakers and the moderators and the panelists for making this happen. Join us next week for the CMIO panel. It's on May 20th between 5 and 6 p.m. You should have received the invite, or there should be a registration email that must be sent, and you must have received it. So please attend if you can. Moving on. Also, there's a latest podcast with Jim Davis, who's the CTO of who you just heard Jim Davis speak. So the podcast is up, and you can listen to the podcast. The link must also be in the newsletter that's being sent. Thank you, Jim, for having it up last night. And then on September 28th, there is the annual FHIMSS SoCal Charity Golf Tournament. The proceeds will be given to Ronald McDonald House. So please participate if you haven't signed up already. With that, thank you for joining us today. I really want to thank all the organizing committee members. Our current president, Jerry Pavia, who's really been instrumental, who's actually motivated all of us to do this whole long session when we initially planned to do a 1-hour session. So thank you, Jerry, for being the driver behind this event. And Madhuri, our board member, and you've heard her moderate a panel. Thank you for putting together some awesome panels. Crystal, our VP of programs, thanks for being there, the whole day and making sure that everything's going smoothly. I also want to thank Leroy, Don. So thank you, both of you, for your participation. And Mary, thank you for putting together the enterprise health IT panel that we just heard. And I also want to make sure that Simone, thank you for marketing our event to all the members. And most importantly, I really want to thank Joanne Underwood. Joanne, thank you. We couldn't have done it without you. So thank you so much. This event would not have been possible without Joanne and Midori working together. And Joanne, thank you for all the hours you put together, put in to make this happen. So it was such a smooth conference. Thank you for making it happen, Joanne. And I wish all of you have a good afternoon. We look forward to seeing you in person probably next time. So thank you, everyone. Have a good afternoon.